I should encourage you to come forward if you want to, but I know nobody will, so it's just whatever you want to do. But raise your hand if you have questions and things such. Again, good morning. And I'm Jim Leverenz. I'm the director of the Cleveland Lou Ruvo Center for Brain Health, which is a dementia clinic. We see everything from, I'm guessing just like you, worried well to severe and very odd dementias. And my one case I'll present is a very interesting case, very complex, but I thought it illustrated a lot of things that we're doing sort of on the cutting edge of diagnosis. I think, unlike almost everybody else, I do have kind of an introduction to dementia that I'm going to talk about, just sort of what's going on. This field is moving extremely rapidly, which is odd because I've been at this for a long time, and the field was not moving very rapidly. And we have new diagnostic tests, new kinds of dementia that we talk about, and now we're increasingly recognized. Probably if you take one thing away from here, is that almost every dementia patient has multiple underlying biologies driving their dementia. So that seems to be now the key, and I think as well as when we talk about the case I present, you'll see how we're using biomarkers, imaging, et cetera, to really sort of identify what's going on. So this is kind of an overview. I'm going to talk a little bit about epidemiology. I don't know if there are any surprises there. What causes dementia, therapeutic approaches, because I think I've already gotten questions about Leqembi and lecanemab and donanemab, so we'll talk a little bit about those. And I'll present a case where we used a lot of different kinds of imaging and biofluid biomarkers to sort of diagnose what was going on. And actually we have an autopsy in that case, one of our research study participants, and we can kind of go over what we saw. And thankfully, I guess our diagnostic tools seem to work there. So again, I don't know if this is any really surprise, just, that our society's aging, the world is aging, the number of dementia cases is increasing dramatically. And just to reiterate that, just older individuals with dementia are just going to increase in number, and they're going to come through your clinic, and you'll need to be prepared to see them. Probably the most common thing I hear from people, I think actually when I was talking to someone earlier over breakfast, they were talking about somebody going down to the basement to pick up 3 things and coming back, and they could only remember 1 and they needed to be rehinted. That's pretty normal age-related phenomenon. If you talk to the neuropsychologists, that starts about age 35. So those of you who are over 35, I'm over 35. Definitely, go back out of the room to get the hint to go back. And that's one of the things I often I talk to the family or the patient with is do hints help? And when they say, yeah, all the hints help. And I'll show you, that's why I like to use the MoCA test, because there's the hint component that you can do, and you can really see if somebody gets all 5 items correct with hints, or 4 out of the 5. It's not probably a classic amnestic picture, and that can be really helpful in terms of defining what kind is going on. But this is the most common thing I see, and I do like to think that my file folders are getting full, and that's why I don't remember something, but you never know, right? I did want to define some things, particularly now with the new therapies, lecanemab, donanemab. MCI is included as a level of cognitive change. And I tend to think about it that there's some sort of evidence there's a change in cognition. In my clinic, we use the MoCA mostly, and then often if we see something, we'll refer them to neuropsychologists. And I know not everybody has an option to do that, but that's kind of helpful, particularly in these very mild cases in terms of defining, is there really something out of the ordinary going on? Generally, you're wanting to see some sort of impairment in one or more of the domains that the neuropsychologist is looking at. And in MCI, I'm really looking for, are they still functional? Probably the thing I usually say, I'll talk to the spouse and I'll say, if you had to leave town for a week, would they be okay on their own? And that kind of really quickly gets you to, some people say, no, there's no way I would leave them alone. Or yeah, I just, I left to go see my aunt or something, and he was just fine, or she was just fine. So that kind of gives you kind of a really brief way to kind of identify if somebody's having functional impairment. Dementia really just goes to that next stage where there's now functional problems. So they lost their job, somebody's taken over the bills, things like that. They can't be left alone for long periods of time. Usually kind of gets you to that dementia stage. Most community members, as you probably know, think all dementia is Alzheimer's or all Alzheimer's is dementia. And as we'll go through here in a second, obviously all dementia is not Alzheimer's disease. Probably second to multi-etiologic dementia is the most common kind of dementia. I think the other thing I like to go to now, particularly in the evolving biomarkers, is that syndrome doesn't equal disease. So you'll see people who have a classic amnestic Alzheimer's-like picture that turn out to have something called late that I'll talk about in a little bit. Or you'll have Alzheimer patients that present with a language disorder, and they'll look like a primary progressive aphasia. And so as we're doing these biomarkers, we're realizing more and more that these syndromes don't always fit actually the underlying biology. So it's just something to keep in mind as we move again more into the biomarker component of disease. So this is a little figure I like to put up. This is actually old research I did. Went back when I was at the University of Washington in Seattle. But this is a community-based sample of dementia. So this was something called Group Health Hospital that's now been absorbed by one of the other big HMOs. But people agreed to having autopsy at the time of death once they were diagnosed with a dementia, and they came to autopsy. So it's a little bit more representative than your classic, say, Alzheimer's Research Center, where you have 50-year-olds with familial forms of Alzheimer's or other kinds of dementias. And what you can see here, I think I have there we go. This is the group that only had Alzheimer's disease. So 14% of this community-based sample of dementia, I think average age was around 80, had just Alzheimer pathology going on. Lots of people with Alzheimer's and Lewy bodies, vascular disease, just as many people with Alzheimer's, Lewy bodies, and vascular disease that had only Alzheimer's. And then something I'll talk about here, because we didn't know about it at the time, but we published a paper. We saw this subgroup of people with hippocampal sclerosis, like you would see in seizure disorders, neuronal loss in the CA1 region of the hippocampus. We weren't sure what that was, although we did look, and they didn't really have a history of epilepsy or seizures, so we just sort of put it in hippocampal sclerosis. But this now is called late for the vast majority of the time. And it's linked to that protein TDP43 that we see in ALS and certain types of FTD. So it's kind of I think about it biologically as sort of a late onset FTD, but primarily they look exactly like Alzheimer's. Almost all these cases had a diagnosis of Alzheimer's disease. They had amnestic dysfunction, as you might imagine, because their hippocampi were losing neurons, so they weren't putting new memories in and struggling, and they almost always get an Alzheimer's diagnosis. So one of the new areas that we talk about. This just proved my point. This is the Rush dementia program, actually much larger than the one I was in. And what you can see is over 75% of their cases have multiple underlying biologies going on that cause the dementia at autopsy. So again, multi-etiologic dementia now is thought to be the most common kind of dementia. So before I go on, please raise your hand if you have questions to get a small enough group, and we've got enough time that if you have questions, please ask. So probably the most common thing, obviously, you can't make a diagnosis of Alzheimer's disease, particularly without evidence of amyloid deposition, and amyloid is on chromosome 21, and so one of the biggest risk factors for having Alzheimer's disease is being Down syndrome, having 3 copies of chromosome 21. We've done a little bit of research in that area. By about age 30, almost every person, pretty much every person we've ever looked at, with Down syndrome has at least some amyloid deposition already. And for some patients where we had access to an autopsy in their teens, already there's amyloid deposition. So just having an extra copy of that chromosome 21 really drives and kind of overwhelms the system and gives you that amyloid deposition that you see early on in Alzheimer's disease. Yeah.
So, and just repeat any question for the people there, but has there ever been any thought of giving these anti-amyloid therapies to Down's kids? Because you know they have it.
Right. No, that's a really good.
There's always, you don't give it really early. Has there ever been a thought of it, or?
Yeah, no, there's ongoing thoughts. Yes, I'm sorry. So his question was about Down syndrome. Have there been a thought about giving the new amyloid therapies to that? And that's one of the areas that people are looking at, particularly in that early stage where the amyloid deposition's there, but we're not seeing a lot of cognitive change or a lot of behavioral change. I had a bit of a cohort at one point of Down syndrome, and I would say behavioral change is probably the most common early symptom that I see in these individuals. But yeah, there is an option, and I'll talk a little bit about Lewy body dementia as well, where we often see coexistent amyloid deposition. At the Alzheimer's International Conference that I was just at, one of the presentations on one of the newest monoclonal antibody, donanemab, they saw evidence that people with sort of lower tau burden, lower tangle burden, but amyloid deposition were probably the people that responded the best. So there's increasing feeling that getting these drugs into people at a very early stage before you have a lot of tangle pathology are the ones that may respond the best. So definitely Down syndrome, definitely Lewy body dementia that's coming down the road as well, at least in terms of clinical trials. We'll talk about some of the caveats there in a minute. The other major change is our neurofibrillary tangles. So this is a drawing by Alzheimer. He was, I guess, kind of like me. He was a dementia guy or a neurologist and a pathologist. And so actually drew these pictures of these tangles he saw in the brain cells that are neurofibrillary tangles. Those are made up of a protein called tau, T-A-U. We all have that. In Alzheimer's, it's hyperphosphorylated. So when you do, for example, CSF testing for Alzheimer's disease, you'll get tau and total tau and phospho-tau, and that's phospho-tau that's fairly specific to Alzheimer's disease, the p-tau. So I'm usually looking for both of these pathologies, both in terms of pathology here, but as well as in terms of biomarkers. So another common dementia, Lewy body dementia, really under that umbrella are Parkinson's disease patients that develop dementia and dementia with Lewy bodies. And generally, I mean, I'm going to give you the specifics, but generally it's just, I base it on which of those two groups, on what starts first. Is this a Parkinson's patient that you've been treating for a half dozen years and now they're starting to develop some working memory issues? Or is this somebody who came in, had been diagnosed, say, with Alzheimer's disease, and you're starting to see they have some unusual features? So you can see in our community-based sample here, there we go, these are everybody that had at least all Lewy body pathology at autopsy. So you can see it was almost 50% of the autopsy cases, and I think it's pretty consistent across the literature. About half of your Alzheimer patients have coexistent Lewy bodies. So we've been trying to pry the data from our Lilly and AZI people on getting biomarkers to see if we can see how many of their participants in these studies actually had coexistent Lewy bodies, because we know it was probably a pretty high frequency. So I always like to throw this picture up because this is Alois Alzheimer here, and this is Friedrich Lewy. So they actually work together. So just like the pathology, they were already together a long time ago. If you look at the number of people who have either dementia with Lewy bodies, Parkinson's dementia, or people with Alzheimer's that have coexistent Lewy bodies, it's a very high frequency. So estimates from a clinical point of view is about 1.4 million Americans. These patients tend to be very difficult to diagnose, and I'm much more empathetic now to this. We have an ongoing autopsy study called the Dementia with Lewy Body Consortium, where we're following people longitudinally, and if it's of any consolation, We've had about 40 autopsies, and 5 of the cases had absolutely no Lewy bodies. And these are Lewy body dementia experts from around the country. So they tend to be a little bit older, more Parkinsonian features, but actually don't have any Lewy bodies. So it can be a very difficult diagnosis to make. And again, multiple trips. Families are very distressed. And we've actually got the funding now, this Dementia with Lewy Body Consortium, to study this. So the classic criteria for dementia with Lewy bodies is that you start with a dementia. So usually there's the so-called 1-year rule, which can be, we use for research, but it can be a little bit flaky, I guess, exactly when did the dementia start versus the Parkinsonism. Core features, fluctuations, visual hallucinations, which is, I think, what a lot of people hang their hats on, Parkinsonism, and then the REM sleep behavior disorder. So I ask those kind of questions. Obviously, I examine them for Parkinsonism. It's always good to ask about the hallucinations because they're not always delusional about them. So I've had a number of patients where I ask, and the patient will say, "Yeah, I see this dog in the corner, and I know we don't own a dog." And the spouse will look and say, "I didn't know you were seeing things." But they said, "Well, they didn't bother me, so I didn't mention them to anybody." But they'll literally see these things and don't always bothered by them. The acting out of dreams can be really helpful. You can get a PSG on these individuals. And the hallucinations, the only thing I would mention there is a lot of my Alzheimer patients will say, "Yeah, I saw," the families will say, "Yeah, he's hallucinating. He said he saw his mother yesterday and she's been dead for 20 years. But I'm really looking for evidence that they're actually literally seeing them, not a false belief like a delusion, but this is actually some sort of visual phenomenon." And that kind of helps differentiate some of those cases. We do DAT scans. I'll show you one of those in a bit. I don't do MIBG. That's something a lot of my European colleagues use. PSG can be very helpful, and we know that the very, very high frequency of people who have a sleep study confirmed REM sleep disorder are going to have one of the Lewy body diseases, either PD, DLB, or multiple system atrophy. So very, very helpful from a diagnostic point of view. So this was my favorite hallucination. The farmer who said he saw squirrels driving tractors in his backyard. He sort of laughed at himself, but he said, "I see them out there." And the spouse said, "Well, there are a lot of squirrels out there, but they're not driving tractors." So I had one of my colleagues put this together for me. So they can be really quite vivid. I think one of the kind of clues, though, is typically they're not that disturbed by them. And they don't have that delusional component. Classic Parkinsonism. The one thing I would say is most of the dementia with Lewy body cases are going to have symmetric Parkinsonism. And so they're not going to have, you're going to see that sort of stoop posture, maybe not a resting tremor. And that's why I think when I look back at the cases where we've been wrong in our studies, it's often because they're a little bit older, they're a little bit stooped, they have some Parkinsonism, but it's very symmetric. And so that can be a little bit of a difficult cure, but it is something obviously I'm looking for. I actually feel a little more comfortable making a Lewy body diagnosis if I at least have an asymmetric resting tremor or something like that kind of pops out during the evaluation. And again, I don't know if most of you have access to sleep study. I know in our center it takes a little while to get them in. I don't know what it is now, maybe a couple months to get a good sleep study. But again, the REM sleep disorder, if they're actually acting out during their dream sleep, then you really, it's very diagnostic for that group is very high frequency. If you talk to Brad Beauvais, who's sort of the king of REM sleep disorder, he says everybody who's going to get Lewy body disease of one kind or another has RBD. I'm not sure that's exactly the case, but it's a very high frequency. And again, if you see that or they come to you with an RBD diagnosis, you know that they probably have an underlying Lewy body disease. Now, that means they can go down any of the synucleinopathy pathways. So they can go down DLB, PD, multiple system atrophy. All of those can be linked to Lewy body disease. So again, as a part-time pathologist, I just have to show you a few pathology pictures. So this is a classic substantia nigra pigmented neuron, and here's a nice haloed Lewy body, just like Friedrich Louis. Does anybody remember where Friedrich Louis thought he saw, that's actually relevant, where he saw the first Lewy bodies? So it was a basal forebrain, so the cholinergic basal forebrain, and I'll talk about how these patients respond extremely well to the cholinergic agents. It's actually, I think it's almost diagnostic when I have somebody that comes in and they have a robust response to donepezil. I literally have had families say it's like he's back to normal. Hallucinations stopped, the working memory's better. It's short acting, all right, it doesn't last forever, but these patients really respond quite well. And this is immunohistochemistry for alpha-synuclein, and so you can see these Lewy bodies here are labeled. The other thing that we can do here is you can see that we're seeing fibrils as well that are stained for the alpha-synuclein, so very helpful from that point of view. So frontotemporal dementia, my guess is, again, especially if you're a neurologist, you're seeing these cases kind of pop through. We generally talk about the behavioral variants, the language syndromes, the motor neuron disease, and the Parkinsonian disorders like PSP, cortical basal degeneration. This is another group where I think you talk about syndrome versus disease. As we've gotten better with the Alzheimer biomarkers, we're realizing that a lot of our PPAs are in fact language variants of Alzheimer's disease. We see a lot of patients who come in with an FTD diagnosis. We do the biomarkers, and in fact, they've got Alzheimer's. And I'm somewhat calmed from a diagnostician point of view that Marcel Messelam, if any of you know him, he coined the term primary progressive aphasia. He always liked to show a case that he diagnoses PPA, and then he shows the CSF testing, and it was Alzheimer's disease. So even the world's expert in this can be fooled. Mostly show this, that the underlying pathology that we see in these disorders can be either a tauopathy, either a 3-repeat or 4-repeat tauopathy, TDP-43, which is a protein that we link to ALS, but we now link to subtypes of FTD, and is something that we're increasingly recognized fits to that hippocampal sclerosis, that yellow picture I meant, yellow component. So we think those patients that have the kind of classic Alzheimer's-like picture, but have hippocampal atrophy, loss of neurons, a lot of them have TDP-43 pathology. And in fact, a lot of Alzheimer patients, kind of like the Lewy body, also have coexistent TDP-43. And then there are a whole bunch of really rare components here. So I think the last part, I'll talk about this yellow picture here, the hippocampal sclerosis. And this is a paper we published a number of years ago, now over 20 years ago. I'm getting really old. What can I say? But this was from that community-based sample. And what you can see here is sort of a normal hippocampus over here. You see the CA1 sort of, if you look through the microscope during your residency, see these nice neurons here. And this is the case here that we saw. You can see really just kind of that massive loss of neurons in the CA1 region. Important part of encoding new information, so these patients were very amnestic. You can see this is the glial staining here, and you can just see it's densely gliotic. And what you see on the MRI is just hippocampal atrophy, so it looks just like your Alzheimer cases clinically, and then in terms of imaging, and then you do the AD biomarkers and they're negative. So one of the things that we typically do is we kind of try to lay this diagnosis people of the late, we call it now, on people who are coming in, have negative biomarkers, and have this hippocampal sclerosis on imaging. Generally it's called, I'll talk about late means in a minute, but it's been associated with older age. Generally you're thinking about 80-year-olds. But I think actually now that we're starting to look for it more frequently, we're seeing it even in younger individuals, and maybe there's a spectrum of people with early onset TDP-43 that have more of a frontotemporal picture, later onset that have more of a hippocampal Alzheimer's picture. Yeah.
I assume we don't see increased seizures in these patients.
No, yeah. So the question is about seizures, and I think I sort of referred to that. When we looked at those cases in this study, we did not see an increased frequency of, we had these medical records, so we could go back and see. So this is not seizure-associated CA1 neuronal loss. We actually now know as well, because we see in most of these this TDP-43 deposition, that these cases are a different neurodegenerative process than a seizure disorder. And so this is why we call it late, because it's harder to tell your patients that they have limbic predominant age-related TDP-43 encephalopathy. But I do kind of like the late acronym. And basically, they have that hippocampal loss, and they have these TDP-43 aggregates like we see in ALS. So this is something I think you're going to hear more and more about. You could see how frequent it was in our community-based sample. Again, I think most people are seeing that this seems to be the case. That's probably 10 to 20% of all of your dementia cases, look very Alzheimer's-like, and it's a co-pathology in a lot of different kinds of diseases, as you'll hear about when I talk about my case.
And on MRI, can you see mesial-temporal sclerosis, or is just...
Yeah, you see hippocampal atrophy, but it looks exactly... So there's a question about, can you see this on the imaging? And you do see that hippocampal atrophy, but it looks identical to what we see in Alzheimer's disease. Maybe a little more severe, but when I'm thinking about somebody, again, who I see and they have that hippocampal atrophy and they have an amnestic picture, and then they, we do biomarkers and they're negative, I'm thinking late. Yes? We haven't done like prospective EEG. It's a good question because we think about hippocampal sclerosis. When we looked at the medical records of those patients I originally described, we didn't see an increased frequency of seizure. And of course, you always wonder, like at night, are they having seizures or something like that? When we look at hippocampal sclerosis in seizure disorders, we don't see that TDP-43 deposition. So this seems to be a neurodegenerative process, but it can look, again, a little bit like your seizure patients that have medial temporal seizures and have CA1 neuronal loss.
I think the name is kind of confusing. Sclerosis is, you should see, like you said, signal in the MRI.
Uh-huh.
The sclerotic changes, I believe what you're describing is basically atrophy.
Yeah.
Signal change in the T2 or later sequence in the MRI.
Yeah, you don't tend to see, I haven't seen that. Mostly I'm looking at hippocampal atrophy. So it can be confusing. As I said, it can look a lot like Alzheimer's disease. Was there another question there?
Yes, so how do you actually make the differential diagnosis between Alzheimer's disease, for example, and frontotemporal dementia? Is it biomarkers now, and clinical features like language against other things, or how do you determine it's frontotemporal dementia or Alzheimer's?
Sure. That's a really good question. So questions about how do you differentiate, say, AD versus this late or frontotemporal dementia, because we know that some of the ADs will present like they have FTD. They can look very clinically like that. And that's where you kind of have to do the biomarkers. Either the amyloid imaging can be useful in that circumstance, or spinal fluid biomarkers. And I'll talk about biomarkers here in just a second. But those are the ones that we typically use. So in some ways, it's getting back to the old days where it's a diagnosis of exclusion for non-Alzheimer dementias, although we do have a better biomarker for Lewy body disease now that I'll talk about. So we do have a lot of laboratory testing that we can do, and I'm going to skip ahead because I want to make sure I stay on my time frame here. Okay. From a CSF point of view, we typically measure the amyloid protein, the A-beta-42 that we see deposited in the plaques. We also do phosphorylated tau, which is fairly specific to Alzheimer's disease. We do total tau and neurofilament light, which are kind of non-specific neurodegenerative markers. We are increasingly starting to think about doing GFAP, although I'd say clinically I'm not doing that much. The alpha-synuclein seeds, so synuclein aggregate assay, is something we're increasingly doing in our spinal fluid. And now there's a skin biopsy, although I know my colleague Hubert, who'll talk later from movement, I think they do a lot of skin biopsies. I tend to like to do spinal fluid because I can go both looking at alpha-synuclein seeds for Lewy body pathology, as well as look at Alzheimer markers. I can also look for autoimmune disorder, all with one test. I kind of like the simplicity of that, so to speak. We are not there yet, but we hopefully will have the TDP-43, some sort of seed assay in the near future that allow you to look at that late component. So when I'm seeing a patient, I get a good history. Ultimately, I'm going to do a neuro exam. I like to do the MOCA. If I can get a neuropsych testing here. I'll do this. Yeah. Yes, I have them draw a clock in the. I don't do what is that, mini cog? I don't know if you remember the mini cog, where you give them 3 words to remember, have them draw a clock, and then come back and see if they remember. I usually, again, I'm a dementia clinic, so we're going to do something a little more involved. So usually we do the MOCA, the Montreal Cognitive Assessment, and I'll show you a picture of what that test looks like.
I find that draw a clock is a good test many times. They kind of neglect the left side.
Right.
That can be more typical of Alzheimer's. What do you...
I think, so she's asking about how do I interpret a clock drawing? I mean, you can definitely see neglect in a clock, and I've seen people with strokes and, visual cortical dysfunction, and they'll have trouble with that. When I see really kind of mild cognitive changes, but they're really struggling with the visual spatial components, then I'm thinking like Lewy body disease, because they tend to have a lot of visual spatial dysfunction, visual dysfunction. But again, I'm just looking for clues, and then I'm often doing the biomarkers to be understanding what the underlying biology is, particularly relevant in the new medications that we have now. Hopefully I answered your question to a degree. So I usually will do either a spinal fluid test if this first analysis with the history and the exam and the neuropsych, there's something going on. We offer some sort of biomarker, either the spinal fluid or the amyloid imaging. For Alzheimer's, the spinal fluid, if it's a more complex case. We might do, besides the structural MRI, I would say we use something called NeuroQuant, which adds about $100 to the MRI and actually gives us volume measurements of the different regions of the brain. We find it extremely helpful for those cases very early on, where you're trying to say, is this really something going on or not? That sort of MCI case. And again, like in late or Alzheimer's, we'll see that hippocampal atrophy, 5th percentile, way below average for the age. I personally find, I'm so used to looking at 80-year-old brains that when I see a 50-year-old brain, it's hard for me to determine if there's atrophy in, say, a young onset case. So that's where I find the volume measurements to be very helpful and tell me, really, this is not a normal MRI. So,
Could you just comment on, if I go for my executive physical, asking about getting allele testing for genetic risk? Helpful, not helpful, it just causes problems in people? What's your take on that?
So in terms of so he's asking about genetic testing. I generally have not done genetic testing unless it's a very early onset case or there's a strong family history. So we're talking about under age 65, multiple family members, things like that. Up until the new monoclonal antibodies, the ApoE testing has not been something that I've used. It's not diagnostic. And you do have to remember from a genetic counseling point of view that if somebody's an E4 homozygote, that means that the family member that brought them in, the child, is probably definitely at least has one E4 allele, so has a higher risk. So you have to kind of take that into consideration. But as we'll talk about in a second here from the therapeutic interventions, the monoclonals, we know the side effect profile is different between the different E4 alleles, and so we do that testing now. And I was talking to somebody earlier, and a lot of people were having trouble getting the E4 testing. They were sending them off to 23andMe to get it done. So this is just somebody who had hippocampal atrophy. Again, we get these volumetric measurements in our hands, but you can generally see this, very impressive hippocampal atrophy. This could be late. This could be Alzheimer's. It could be any of those. This is an amyloid scan, and you can just see it's lighting up the cortex here. CSF, generally what we see is somewhat counterintuitively in Alzheimer's disease, the tau levels go up, but the amyloid levels actually go down. So I like to think about it as the amyloid is being bound up in the plaques, so that's why it's not being released into the spinal fluid. And the tau is an indicator of neurons dying, particularly the phospho-tau that they do in the spinal fluid testing can be helpful from that perspective. I mentioned this briefly. There is now a new test using the same technology we use to diagnose prion disease, looking for aggregated synuclein. It works extremely well. I would say in our autopsy studies so far, almost 100% specificity. Probably sensitivity for somebody who has more limited Lewy body pathology in the brain. It can be negative. And you can do it in the spinal fluid. There's a immunohistochemistry skin test that you can do as well that's commercially available. I don't think we know how well the skin test works yet. I think people who really like to do it think it's really very good. I'm almost more worried about false positives than false negatives in that, but I don't actually have the data. We're trying to put together a grant to compare CSF to skin. Yeah, we kind of went through some of this. I think you will start to see more increasing plasma biomarkers as we go along. So I talked just briefly about the drugs that we have available. We've had these guys available to us forever. The only thing I would say here is usually the cholinesterase inhibitors improve working memory. So they're just as bad about remembering what happened yesterday as they were before, but generally their working memory might be a little bit better. The cases I really like to treat with these are the Lewy body dementias. They respond really quite profoundly. And again, often if I get somebody come back and the family says it's like it's back to normal, I'm always thinking in the back of my mind, maybe this is an early Lewy body dementia case. And it actually helps because it makes the hallucinations go away. Patients will say, yeah, it's weird. My hallucinations went away.
How often do you see visual hallucinations? I think that it's not that frequent.
Yeah, well, again, I have a strong bias. Her question is, how often do you see visual hallucinations? Well, number one, I always ask. That's important. But, I have a memory clinic. I see it in most of my Lewy body patients or a history of it. But it can be negative. It's just important to ask because patients, if they're not bothered.
Very bad. That was the only thing.
Yeah.
I look for it.
You're not seeing it a lot. Okay. It's not diagnostic alone, and many of my Lewy body patients never had it, or their primary doc thought that they had Alzheimer's and so put them on donepezil, and again, it can really help make the hallucinations go away. So if I had to say, in the field, there's something called Diamond Lewy, which is how you manage these patients. It's we all start cholinesterase inhibitors in these guys because they do so well. Just data on that. I'm not going to go. The other thing that we tend to see besides the reduction in hallucinations is we see improvement in apathy. So they're more interactive. And I think that's what the family picks up on when they do better, is they come a little bit out of their shell. And we see that across the dementia types. And memantine, I'll usually add on top. The one thing I mentioned about memantine, when you look at the behavioral outcomes in the original studies, they actually saw an increase in hallucinations. So it's something where maybe my DLB patients, I don't add memantine. So I want to focus a little bit on the new therapies here. Yes, sorry. No.
Before you go into this next stage, I just wanted to ask you, have you seen Parkinson's disease patients improve in terms of their cognition with just Parkinson's medication? Not yet talking about cholinesterase, but just Parkinson's medicine improving cognition.
I certainly have. So his question is about, have I seen improved cognition in Parkinson patients when you're just treating their Parkinson's disease? I think I've seen people where it seems like, with a little carbidopa, levodopa, that they're a little quicker. And course, there's a sedating aspect that sometimes can come with that, so you're kind of always playing that off. But yeah, I think I see it anecdotally. I don't know that we have a good placebo-controlled trials, so to speak, because most of the Parkinson patients come in on a lot of drugs by the time they come to see us for dementia. I would say I try to focus in on managing their carbidopa-levodopa and get them off the agonist, because that can really cause a lot of the behavioral disturbances. And there I tend to see maybe not worsening dementia, but more of the hallucinations and behavioral changes with those. So that's usually been my approach. Yes?
Yes, and I don't know if you're going to touch on this later on, but what about depression in these patients with dementia?
Yeah, depression's very common, particularly in the Lewy body patients. I think the apathy that we see in almost all the dementia subtypes, that decreased interest in interaction, is often interpreted by the family as depression, and the family doc will put them on something, and it doesn't seem to help. And that's where the cholinesterases can be helpful for that apathy. But when it's true depression, they're really depressed. They're, we see that a lot in the Lewy body patients where they have a little bit more insight. Then I use an antidepressant. Again, I'm very old-fashioned. I use the old sertraline, Zoloft, can be really helpful. That's also sometimes useful for irritability in Alzheimer patients, so I kind of get a double hit for that. But yeah, treat it if it's there. Generally, antidepressants don't work well for the apathy that you see across the dementia subtypes. Sure. This is just the lecanemab data showing basically that people on lecanemab, the monoclonal, is an every 2-week infusion, slowed in their progression over time versus people on a placebo down here. So not dramatic, doesn't stop the disease. I try to be transparent with patients on what we think we're going to see, which is just that you're going to get a 6 month to a year sort of slowing of progression over time. I think my younger onset patients tend to be more interested, or their families, in doing this, and it's for people with mild cognitive impairment or mild dementia. So people who come in, unfortunately now, with moderate dementia, their MoCA's a 10, things like that, they don't qualify for that.
Do you do genetic testing?
We do. And so everybody who's going to get one of these monoclonals should get ApoE gene testing, because that influences the frequency of the side effect profile. So the ARIA that I think I talk about here in a second is determined. The frequency is based on how frequent what their ApoE genotype is. So the 3 3s are the lowest, the 3 4s next, and the 4 4s are the highest. So you see this sort of dose response to the ApoE to the ARIA side effect that you see. And just kind of laying some of that out. And then the newest drug that was just approved by the FDA that we're not giving yet, but although we've given it in drug trials, is donanemab, which comes from Lilly. This is a once a month, so it's easier to give than the every 2 weeks with lecanemab. There's a sense that maybe the side effect profile is a bit higher. One of the benefits, I think, of this drug that you might start to see is that you can stop it after a year or so if you have evidence that the amyloid is gone. So let's say you repeat the amyloid imaging, it's now negative. At a year of therapy, you can stop. Whereas with lecanemab right now, we're just giving it 18 months every 2 weeks. So maybe a little bit heavier. Yeah. And we kind of use a 16 and above. So his question is, what do you use for that MCI and mild dementia category? Generally, we kind of use the MoCA as a test. So sort of 16 and above kind of puts us in that MCI to mild dementia stage. We haven't had to. But we often, again, in my clinic, we have embedded neuropsychologists, so we get it in everybody. But yeah, I'm often looking at the neuropsych report, but we often just base it on the MoCA in terms of whether they qualify or not. So the 3 components of that, but it's just good to reiterate. We want them to be in that MCI to mild dementia stage. We want to know what their ApoE genotype is. Personally, I do give E4 homozygotes the drug, but I let the family know and I let the patients know that they're at higher risk for developing the ARIA, the amyloid-related imaging abnormalities, and let them make that choice. And as I was talking to somebody earlier, everybody's a little bit different in terms of some families are really gung-ho. Some people say, leave it, I don't want to do it. But I do that to really get a good sense of how they're doing. And you need, with the donanemab, I think you're going to have to do amyloid imaging because you're going to have to demonstrate that it's gone away, and then you can stop drug.
5 minutes.
And I know. I haven't even gotten to the case. Good questions, though, and I hope this was informative. So I'm going to skip this guy here. Just talk a little bit about ARIA. Probably I think if I could say anything, if you're going to do the monoclonals, you got to follow the order of doing the MRIs. Most of the side effects are seen in the first 6 months. The most common ones are either ARIA-E, ARIA-H, which is the hemorrhage or the microhemorrhages, or ARIA-E, which is the edema, and you can kind of see this sort of focal area. Our neuroradiologists now put out a report, and they tell me how many microhemorrhages they are, although I always look at the scan myself because sometimes they don't pick them up. They're looking at a lot of scans over time. But these are the things, again, you want to confirm the Alzheimer pathology. They have to have Alzheimer's. Do the genetic testing. Get a baseline MRI. If they have 5 or more microhemorrhages from the start, then you don't start them. They've got probably underlying CAA, amyloid angiopathy, and they're not candidates at this point. So I'm down to like 8 minutes. 8 minutes, that's according, so you have 4?
Well, we got to stop at the.
Okay, that's what my timer here says. They started it late. No, you get it. Let's not talk about the time. Any questions at this point? Yeah. Mm-hmm. All right. Well, if you saw that he was responsive to so she's asking about a case of somebody that was on carbidopa-levodopa and did well on the Exelon patch. And she was asking about, she was trying to he had postural hypotension, and so you tried taking him off his carbidopa-levodopa, and he became extremely Parkinsonian, which is a good sign that he actually has an underlying, probably Lewy body disease. That's the kind of patient, again, I would stick to the carbidopa-levodopa. Postural hypotension, very common across the Lewy body disorders. So not necessarily PSP, but I think if you, again, this is where I probably would pull in my experts on the, autonomic dysfunction to take a look at that. But you are kind of in a rock and a hard place, right? Because they really needed that carbidopa-levodopa. I try to encourage them for salt intake and all the things that you do for postural hypotension. I don't know that you would necessarily do that unless it's going to influence your therapy. So she's asking about, should I do CSF testing? You could, if the family really wants to know. The SynTap test, which is one that a company called Amprion does for the synuclein, and then the Alzheimer test, there are a number of different companies that do that. Okay. Yeah, again, I think for somebody who's very early on, so she was asking about someone with a lot of with hypersomnia, sleeping a lot. What was the other? Dizziness. Yeah, I find dizziness, I don't know how the rest of you are, dizziness is such a tough one. But, I check for postural hypotension, encourage them for high fluid intake. But yeah, those are the kind of some of those little subtle things that may make you wonder about Lewy body disease. If you really wanted to know, you need to do one of these synuclein tests, either spinal fluid or the skin biopsy. Again, the CSF you can test for Alzheimer biomarkers at the same time, so you can kind of get multiple answers. And I get cases that come back and they're Alzheimer positive and they're synuclein positive, and they just have AD with Lewy bodies, or the old Lewy body variant that we used to call it. So I'm not going to get through this challenging case.
We have till 10 after.
That might be more interesting.
So you have probably 8 minutes.
8 minutes. It's going to be a really tough one. All right, so this was a 73-year-old guy that came in to see me in late 2018 with 2 years of neurologic symptoms, difficulty using his remote. He did say he was having visual hallucinations, although, again, this is kind of one of these ones where I'm wondering, is he really seeing his mother? But there was some evidence that he was having visual misperceptions, seeing things and interpreting them as something else. And there was a question of whether he had REM sleep behavior disorder. So on exam, he did have Parkinsonism, although like typical patients with DLB, although he was a little more asymmetric, which made me feel like maybe this really is probably maybe a Parkinsonian, so to speak. His MoCA was just a 14. I'll show you that in a second. MRI with mild atrophy and some white matter changes. We started him on donepezil, and we enrolled him, of course, in our research study, thinking he might have DLB. So this is his MoCA. He was 14 out of 30, but one of the things I wanted to show you here is that with the hints, he got 4 out of the 5 questions correct. So he's not a classic amnestic picture from that perspective. And actually a little more frontal subcortical. Usually when I think, my neuropsychologists tell me when you think about semantic fluency being more medial temporal, whereas frontal subcortical is more the letter fluency, and the letter fluency here was a little bit on the low side. And although I think I show it in the next one, in his proverb interpretation was a little bit on the concrete side. And this is something I throw into our MoCAs. This is not part of the MoCA, but just the idea of how well are they interpreting these sort of people in the class houses shouldn't throw stones. And even people who've never heard that before will say, I know what that means, and you can interpret that. But his interpretations were kind of concrete. So given our time, I'm going to just proceed ahead. So this is the original MRI. So we see some atrophy. So, we were wondering about Alzheimer's disease here in the medial temporal lobes. He did get more and more Parkinsonian. I think if I go to the next one, his UPDRS initially was 23. I don't know how many of you use that, but that's mild to moderate Parkinsonism. And later, as you'll see, it went up to in the 40s. So it became very Parkinsonian. So we're really thinking there was a Lewy body component to this. The confusing aspect to this guy, I'm gonna throw it. So we as part of our clinical study, we do the smell identification test. And this is something the Parkinson's people have been teaching us as well, is that these patients have a lot of early smell abnormalities. They really have anosmia or dysosmia or whatever you want to call it. And this guy did not do very well with that, even though, and again, I was confused by this, that his memory wasn't really too bad. And I'm just going to focus again, because we're running out of time. We've already gone through this. So when he came back again, his Parkinsonism was dramatically worse. And he did start to have a left upper extremity resting tremor, which really made me think this was a Lewy body disorder. His DAT scan was abnormal and consistent with what we were seeing clinically, so you don't see the tail, especially over here on what is the right side. And then the other thing that got very confusing was most of my Lewy body patients have almost no atrophy. And this guy has really quite, in its follow-up MRI, has really quite dramatic frontal atrophy. And so we did spinal fluid testing on him. His A beta 42 was low, which means we knew he had amyloid deposition. Actually, his p-tau, you would know this off the top of your head, but this was a normal range. It's kind of high normal. So we were thinking maybe amyloid deposition, but not a lot of p-tau. He did have, as we might expect, the synuclein aggregate assay was positive, so we knew he had Lewy body disease. And then the other thing that was very odd about him was his NFL neurofilament light was 26,000, is like 3 times the normal level, which I think kind of fits with that MRI with all the frontal atrophy. So this is a mixed case. That was kind of one of the things I wanted to emphasize. Did you have a question? All right. So pathology-wise, we actually did see Lewy body disease. So here's his nice Lewy body in the substantia nigra, and we saw alpha-synuclein aggregates in the neocortex. We saw some Alzheimer's, although it was sort of intermediate level. So we saw amyloid deposition, as we saw in the CSF. We did not see a lot of tangles. They were pretty much restricted to the hippocampus, so sort of intermediate level, which kind of consistent with that high normal p-tau. And then we saw hippocampal sclerosis and TDP-43. So not your typical case, although, again, mixed pathology. And I thought it was kind of interesting because our biomarkers, everything kind of consistent with what we saw pathologically, in that we had neocortical Lewy body disease with all the Lewy body stuff, the hippocampal and frontal atrophy were associated with late, and then a sort of intermediate Alzheimer's and CAA changes. So I think this is emerging kind of how we're going to be evaluating and treating these patients as we move into the future. I think the tough... I'm sorry? Well, he started with a dementia syndrome, so we called him dementia with Lewy bodies, but they're all in that Lewy body spectrum. It's the same frequency in both, so you can see it in both. So that doesn't differentiate, it just indicates a Lewy body disorder. She was asking about REM sleep disorder. So hopefully that was instructive, and thank you, and you're on to your next case.
I'm not sure who's coming here next, but some of you will come.